A 45-year-old male smoker presented with a cough. I'm showing you his chest radiograph. Describe the findings.
Okay, looking at the images, the PA chest radiograph demonstrates a well-defined lesion in the periphery of the right lung. This lesion forms an obtuse angle with the chest wall and shows smooth tapering edges. These findings are characteristic of a pleurally-based lesion.
Given this appearance, what is your differential diagnosis for a pleural-based mass?
Okay, the differential diagnosis for a pleural-based mass includes chest wall lipoma, metastases from lung or breast primary, and pleural plaques. Other possibilities are a loculated pleural effusion, a subpleural haematoma, neurofibroma, schwannoma, or primary rib lesions like plasmacytoma.
Let's review the cross-sectional findings. I am displaying an axial CT slice of the chest. Describe the findings.
As seen in this axial CT of the thorax, there is a well-defined homogeneous lucent lesion of fat density. This fat density lesion extends through the chest wall into a subpleural location without rib destruction or invasion, which is diagnostic of a benign chest wall lipoma.
How do you radiographically distinguish a pleural-based lesion from a pulmonary parenchymal lesion on a chest radiograph?
Pleurally based lesions are distinguished from parenchymal lesions by forming obtuse angles with the chest wall, having smooth tapering edges, and a peripheral location. Parenchymal lesions form acute angles with the pleural margin.
Let's look at another rib-associated lesion. I am showing you an axial CT of a different patient. What finding is demonstrated here, and what is the underlying diagnosis?
In that case, this axial chest CT demonstrates a destructive bone lesion causing complete osteolysis of the posterior left eighth rib. This appearance represents a plasmacytoma in a patient with underlying myeloma.
How would you manage this patient as a radiologist?
Well, I would compare the chest radiograph and CT scan with prior imaging to confirm long-term stability of this pleural-based fat density mass. Because the CT demonstrates classic features of a benign simple chest wall lipoma, specifically showing homogeneous fat attenuation of -50 to -100 Hounsfield units, thin or no septations, and a complete absence of nodular enhancement or bone destruction, I would communicate these reassuring findings to the clinician. For this asymptomatic simple lipoma, no biopsy, surgical excision, or further systemic staging is indicated, and conservative clinical observation is sufficient. However, if the mass shows atypical features, such as rapid growth, size greater than 10 centimeters, or thick septa, I would recommend a dedicated MRI of the chest wall to exclude a well-differentiated liposarcoma and refer the patient to the specialized soft tissue sarcoma MDT.